Okay, let's look at today's clinical roadmap. We're going to cover 1. Stomach anatomy and blood supply, 2. Congenital hypertrophic pyloric stenosis, 3. Duodenal ulcers and complications, 4. Gastric ulcers and classifications, and 5. The role of H. pylori. Let's jump right in. Section 1. Stomach anatomy and blood supply, the foundation of gastric health. You know, the stomach is just an incredibly resilient organ, and it's firmly grounded by a very specific, remarkably robust vascular network. It relies on a precise mapping of 4 major arteries. You've got the left gastric artery branching from the celiac trunk, the right gastric from the common hepatic, the left gastroepiploic from the splenic, and the right gastroepiploic from the gastroduodenal artery. But here's the absolutely crucial takeaway. The left gastric is the dominant artery. That's the one that bleeds in Mallory-Weiss tears. You also have to watch out because in 15 to 20% of patients, an aberrant left hepatic artery arises directly off this left gastric artery. If a surgeon blindly ligates the left gastric proximally, they can actually cause acute left-sided hepatic ischemia. Now, all of these vessels connect in a dense network right beneath the mucosa. And this gives the stomach its ultimate superpower, extensive submucosal anastomosis. Why does this matter so much to a surgeon? Well, because you can actually ligate 2, sometimes even 3 of those major arteries, and the stomach simply will not undergo necrosis. In fact, during an esophagectomy, surgeons can pull the stomach all the way up into the chest to replace the esophagus, relying entirely on just the right gastric and right gastroepiploic vessels to keep the whole organ alive. It's amazing. Moving on to Section 2, Congenital hypertrophic pyloric stenosis, the infant gastric blockage. Congenital hypertrophic pyloric stenosis, or CHPS, is a classic infant blockage where the pyloric muscle thickens dramatically. This causes an absolute roadblock for food. It most commonly affects firstborn males, especially if they were given the antibiotic erythromycin early on, which actually increases the risk 8 to 9 times. So how do we spot it? Comparing CHPS with duodenal atresia gives us a really clear diagnostic framework. A baby with CHPS is totally normal at birth. Their symptoms, specifically projectile, non-bilious vomiting, only start 2 to 3 weeks later because the blockage is above the bile duct. Contrast that with duodenal atresia, where the baby has bilious, green vomiting right from birth. Timeline and bile, that is your foolproof diagnostic framework. When diagnosing CHPS, the absolute best time to examine the child is while they're actively feeding. If you do, you'll witness visible peristalsis moving from left to right across the tiny abdomen, followed by that projectile vomiting. You might even feel a palpable olive-shaped mass in the epigastrium. But to really confirm it, ultrasound is the gold standard. We're looking for highly specific criteria here: a pyloric muscle thicker than 4 millimeters and a pyloric channel longer than 16 millimeters. On an X-ray, this blockage shows up as the classic single bubble sign. Now, the constant vomiting sets off this fascinating, honestly kind of wild metabolic cascade. The baby is constantly vomiting out stomach acid, hydrochloric acid, which immediately causes hypochloremic metabolic alkalosis. To fix the alkalosis, the kidney tries to eliminate bicarbonate, but it has to pair it with sodium. So now the body is losing sodium, which triggers the release of aldosterone to frantically pull sodium back in from the urine. But the kidney can't just take sodium for free, right? It has to swap it for something else. It starts by throwing out potassium, causing hypokalemia. Finally, when potassium levels drop dangerously low, the body makes a desperate compromise to survive. It starts throwing out acid into the urine, even though the blood is already alkalotic. We call this paradoxical aciduria. The only way to fix this intense imbalance is with a very specific IV fluid. Have normal saline plus KCl plus dextrose. Once you've got the baby's fluids corrected, you fix the blockage surgically with Ramsted's pyloromyotomy. The steps are actually really elegant. The surgeon cuts the outermost serosa layer, splits the thickened muscle, and allows the inner mucosa to bulge out completely intact before suturing the serosa back over. But here's the absolute kicker, the crucial clinical detail. If you perform this flawlessly and the inner mucosa remains uninjured, the mother can start breastfeeding the child in just 4 to 6 hours. But if that delicate mucosa is accidentally nicked, you have to wait a full 24 to 48 hours before feeding can begin. All right, Section 3, duodenal ulcers and complications, the acid eaters. Duodenal ulcers are incredibly common, specifically appearing in the very first segment, D1, driven heavily by H. pylori infections and massive acid hypersecretion, which brings us to a major clinical question. What is the single most common cause of upper GI hemorrhage? The answer isn't just peptic ulcers generally. It is specifically bleeding from posterior duodenal ulcers. Because these ulcers sit on the back wall of the duodenum, when they erode deep enough, they chew right into the massive gastroduodenal arteries sitting directly behind them, causing severe hemorrhage. Now, while posterior duodenal ulcers bleed, anterior duodenal ulcers, they tend to perforate. They spill stomach acid into the peritoneal cavity, causing sudden, board-like abdominal rigidity. If you take an erect chest x-ray of this patient, you'll actually see a dark crescent of air, gas under the diaphragm. But remember this, and this is absolutely crucial. Gas under the diaphragm doesn't strictly mean a perforated ulcer. It signifies any hollow viscous pop. It could be the colon, the small intestine, or the stomach. It literally just means a tube with air in it has burst. So if an ulcer has perforated, surgeons use a brilliant technique called the Graham's patch, or omental patch repair. Think of it exactly like fixing a punctured bicycle tire. The surgeon floods the abdomen with fluid to look for the air bubbles, locating the leak. They freshen the edges of the hole, and instead of a rubber patch, they take a piece of the patient's own fatty omentum, stitch it securely right over the hole, and then check for bubbles again. Now, very rarely, a posterior duodenal ulcer will perforate, but because it's on the back wall, it doesn't spill into the main abdominal cavity. It leaks backwards into the retroperitoneum. This fluid can track all the way down the right side of the body, causing intense pain in the lower right quadrant. We call this Valentino syndrome, and it mimics acute appendicitis perfectly. You might also see the renal veil sign on an X-ray, where air surrounds the right kidney like a thin veil. Tricky presentations indeed.
To even see these tricky posterior perforations, a surgeon has to perform a maneuver called cochorization. This simply means aggressively mobilizing and lifting the duodenum so you can look behind it. And if the perforation is giant, like over 2.5 centimeters, a simple patch won't work. Surgeons have to use a complex triple tube technique, involving a decompression tube in the stomach, a feeding tube in the jejunum, and a drainage tube straight into the duodenum to give the bowel total rest. Moving on to Section 4, gastric ulcers and classifications, managing stomach ulcers.
Diagnosing gastric ulcers relies heavily on endoscopy. But if an ulcer is hiding high up in the fundus, the top of the stomach, the camera might just look right past it. Gastroenterologists sometimes have to perform a clever U maneuver, retroflexing the scope inside the stomach like a periscope, just to spot those high hidden lesions. Once you find it, you must follow this golden rule. Always biopsy the edge of a perforated gastric ulcer. Unlike duodenal ulcers, which are almost entirely benign, gastric ulcers carry a significantly higher risk of underlying malignancy. You absolutely must rule out gastric cancer before you just patch the hole and move on.
To manage these, you need to know Johnson's classification, which breaks them down into 5 types. Type 1 on the lesser curvature is your standard, most common ulcer. But types 2 and 3, they act like duodenal ulcers because they're caused by acid hypersecretion, which means they actually require an acid-reducing vagotomy surgery. Type 4 ulcers sit dangerously high up in the stomach body and have the highest bleeding risk because they sit right over that dominant left gastric artery we talked about earlier. To fix a type 4, surgeons often have to do complex reconstructions like a Pauchet or Sendus procedure, essentially creating a brand new pouch out of healthy stomach tissue. And type 5 simply refers to diffuse ulcers caused by NSAID painkillers. Okay, let's lock in this direct high-yield clinical contrast before we move on. If you have a duodenal ulcer, the most common complication you're likely to face is severe bleeding. However, if you have a gastric ulcer in the stomach, the most common complication you face is perforation. 2 different environments, 2 very distinct major risks. And finally, Section 5, the role of H. pylori, the bacterial culprit. This bug is an absolute survival expert. It secretes an enzyme called urease to neutralize the harsh stomach acid around it, allowing it to comfortably colonize the stomach lining. Once it's settled, it uses specific genes, known as KEG-A and VAC-A, to release cytotoxins that aggressively damage the tissue. The path of destruction it leaves behind is massive. It's the direct cause of 90% of duodenal ulcers and 60 to 70% of gastric ulcers. It triggers type B gastritis and is directly linked to the development of gastric cancers and maltomas. But here is an incredibly surprising paradox. Despite all this damage, H. pylori actually has a slightly protective effect against developing adenocarcinoma in the lower esophagus. And this brilliantly illustrates the double-edged nature of medical microbiology, leaving us with a really profound question. If eradicating H. pylori is completely necessary to cure debilitating stomach ulcers and prevent gastric cancer, but doing so actively removes a natural layer of protection against esophageal cancer, how do we properly balance the body's incredibly delicate bacterial ecosystem? It's a crazy dilemma, right? It just goes to show how interconnected our anatomy truly is. Thanks for joining me on this rapid-fire explainer of the stomach, and keep asking those big questions.